Okay. Now I think we should start. So my name is Samiyati. We are here for the second session of the PLAB-2 teaching course. So today we will be discussing about the history taking, that how effective history taking can be done in the case of PLAB-2. We have been doing history taking since our medical school. As we start our third year of medical school, we start going to the wards and start taking history. It's almost the same pattern, just we have to take care of some points, rule out some differentials, and follow the set pattern by the GMC in order to achieve maximum 4 marks in the data gathering portion. So as far as the start of the history is concerned, first part of the history is introduction. Not only introduction of yourself, but also of the patient and also the purpose of consultation. So for the purpose of introduction, there is a mnemonics, which is known as GRIPS, GRIPS. Don't worry if you don't remember the mnemonics, just get an idea what you have to do in the introduction part. You have to greet, you have to build a rapport, you have to introduce yourself, you have to confirm the identity of the patient, you have to tell the patient the purpose of consultation, you have to gather the information from the patient that why he has come to the hospital, and always you have to smile during the introduction part and during the whole case. Of course, if it's not a breaking bad news. So a simple introduction can be that you can start that like how I started was that good morning, then wait for the patient to say good morning. Don't start in the robotic fashion that good morning, my name is Dr. Sami, I'm here, this. Start the conversation in a natural way. Say good morning, wait for the patient to say good morning. After that, introduce yourself that my name is Dr. Sami Atiq. I'm one of the junior doctors working in this department, working in this facility, working in the A&E, working in the GP practice, whatever your setting is. I'm one of the treating doctors working in this facility. Then confirm the name and identity of the patient. That can you please tell me, can you please confirm your name and age for me? So that we get to know that if we are talking to the right person. So if he will tell you the name, suppose he tells you that he is Mr. White. So Mr. White, well, you will ask that, what would you like me to call you during this course of conversation? So that we can check the preferences if he's okay with the first name or if he's okay with the second name. So after gathering this information, we will be going forward, and if you ask this question, you have to remember this his name throughout the conversation and have to use it repeatedly. Like if he says I'm okay with Mr. White, so you have to use that name Mr. White so that the examiner and the patient knows that you are talking to him, you are getting involved in the conversation. You are not just here to pass the exam, and you're not just here to go through your learned things. Okay, so you will say, it's nice to meet you, Mr. White. What brings you to my facility today? Then he will start telling you that he's here with pain, he is here with some mental issues, he's here with some ethical problems, every kind of problem he will be telling you. Then you will again smile and start exploring the problem more. So this is the part of introduction, that you will, good morning, he will say good morning, then you will say, can you please, my name is Dr. Sami Atiq. I'm one of the junior doctors working in this facility. Can you please confirm your name and age for me? Okay, it's nice to meet you, Mr. White. And then what brings you to my clinic today? This will be your introduction. After the introduction, the patient will be telling you about that, what is his presenting complaint. Suppose he's telling you that he's here with some kind of pain. Pain can be in any part of the body. Now you have to remember certain mnemonics in order to get the maximum out of his presenting complaint. Suppose he's telling you that he's here with pain, you have to cover the mnemonic Socrates, which stands for site, onset, character, radiation, aggravating and relieving factor. Timing can be for two things, which includes that how long the pain has been taking place, and how and what were you doing? Timing can also significant that what were you doing when the pain started. And similarly, aggravating and relieving factor, elevating anything. And S stands for severity. For severity, you have to ask in such a way that on a scale of 0 to 10, can you please tell me that what is your pain scale? Where 0 being no pain at all and 10 being the worst pain you have ever experienced. So this is the way of asking the severity of the pain. And one other important question for us about the pain is that what were you doing exactly when the pain started? Because there are certain indicators for various kinds of problems. Like if there is a backache, he will tell you that he was lifting some heavy weight while the pain started. Or if there was nothing like this, he will say, I was just watching television and the pain started in my eyes, the pain started in my head. It can be anything, like subarachnoid hemorrhage can take place spontaneously without any previous symptoms. Likewise, there are other symptoms like vomiting, other symptoms which you have to cover the mnemonic of 40 para. 40 para, F stands for frequency, O stands for onset, duration, progression, aggravating and relieving factor, A stands for anything else. Okay, anything else can be you give the opportunity to the patient to tell you something he knows. If you ask this question, there's anything else, the patient may say you what you want to know, doctor. Then you have to use your own skills and to dig out the problem. Now, third case is the incident history. Incident history, you use this incident history when there is some kind of incident, like the patient has fallen down, the patient has a suicidal history. So you use incident history where we take the history of before, during, and after. Like if a patient had a fall, then you will be asking that what were you doing before the fall started? Were there any sweats? Were there any loss of consciousness? Were there any extended period of not taking meal? You skipped some meal, and were you feeling dizzy before the fall? And likewise, the questions relating to during the fall. That did you remember the fall? Did you remember the incident? Did you wet your clothes? These are the questions which you ask during the incident. And after you can did you receive any injury? Was there any vomiting? Was there any fever? Was there any fits? You can ask this question in the after section. So these three are the certain mnemonics which covers most of the topics of the PLAB-2: 40 para, Socrates, and incident history. This is the general format which is followed almost in all the cases, except the ethical counseling and the angry patients and breaking bad news, where you don't usually take so much of history. So it total takes about 15 components. This was the first component of your history taking introduction. This is the second component of your history taking, which is presenting complaint. The third component is the rule out differential diagnosis. This is one of the main component of PLAB-2. It will be the basis of your pass and fail. If you are ruling out the diagnosis, differential diagnosis well, if you are not ruling the diagnosis well, the examiner will sense it that you are not well prepared, and he can give you a low score on your exam. So in case of differential diagnosis, when we will be starting our specific cases to each topic, like we will be studying approach to headache, approach to ophthalmology, approach to suicide cases, approach to diarrhea, approach to chest pain, approach to cough, we will be discussing differential diagnosis in detail. But let me go through an example. For you in this case. Like in the case of headache, there is a number of differential diagnosis. Like the headache can be due to the subarachnoid hemorrhage. The headache can be due to subarachnoid hemorrhage. The headache can be due to the stroke, this TIA. There can be meningitis. There can be encephalitis. There can be tension headache. There can be cluster headaches. There can be migraine, meningitis. Even the ophthalmology cases can overlap with the headache, like you can have the closed angle closure glaucoma. In the cases, all these are the differential of headache. Now, if a patient came to you with a complaint of headache, that I'm having pain, after completing Socrates, like site, what is the site, what was the onset, what was the corrector, you have to read out all differentials, especially the red flag differentials. You have to ask about the patient that when the pain started, was it gradual in onset, was it sudden? And in which part of the head it was there any fever, was there any cough before the pain started, are there any eye symptoms there. In this way, you will be able to narrow down your approach to a specific case. Like in the case of a subarachnoid hemorrhage, the patient will be telling you that pain started suddenly, and it is the worst pain he has ever experienced, which you already know that's a thunderclap headache, and it's the worst pain the patient experiences. And there will be no certain risk factors, but there can be sites like in the past he had hypertension and various other problems. Similarly, in the case of ophthalmology, there can be closed angle closure glaucoma, which can be patient can be presenting you with the red eye, painful loss of vision and sudden loss of vision, extreme pain in the eye, extreme pain in the head. So these all the symptoms point out towards a subarachnoid hemorrhage. So you will be ruling out each case, and we will help you. And through our course, we will help you narrow down the differentials. This will be the main chunk of our discussions in the future. When we will be starting each specific case topics. Then, after ruling out the differentials, you can do it along with your differentials, but if you have missed it, you should always remember that you have to rule out the red flags. There's a separate marks for that in this section, in the PLAB-2 marking, that you are ruling the red flags out. If you're not ruling the red flags out, you will be scored less. So for ruling out the red flags, there's a mnemonics which is known as FLAWS, FLAWS. So F stands for fever, L stands for lethargy, A stands for loss of appetite or anemia, W stands for weight loss, S stands for night sweating, etc. So for the fever, you can ask a simple question: are you running a fever? Lethargy, you can feel: are you feeling tired? Do you feel tired lately? For the loss of temperature, has there been any change in your appetite? For anemia, there are specific questions that, like, you won't be asking the straightforward question that to the patient that do you have anemia. You will ask the patient in such a way that do you feel the racing of heart? Can everybody please mute your mic, please? Okay, thank you. So, and you will be asking question that do you feel the racing of your heart? Do you feel tired? Do you feel that you are experiencing headaches? These are the questions you will be asking for anemia. So there will be night sweating. So these cases point out towards a cancer, TB. These dangerous signs should be ruled out in almost all of the cases if you're feeling relevant. So after the red flags, after you are done with the 4 components above, you will be coming towards a major chunk of your history, for which we have a mnemonic which is known as P3, Meftosa, and DESA. These are the mnemonics. You can make your own mnemonics. Various people use these mnemonics for their own ease. So for this component stands for P3 stands for personal history, past medical history, and previous similar episodes. After doing above 4 components, you will be coming down to this. You will ask that you do have any personal history of diabetes, hypertension, and any similar episodes of such kind. For example, he comes with headache. You have to ask, do you have similar headaches in the previous years or previous time? Similarly, F stands for medication. Have you been taking medications for any chronic disease? All these components are extremely important to us because patient can behave with any kind of symptom. Like he can behave with the analgesic nephropathy. If you don't take the medication part of the history, you will be missing the diagnosis. If the patient is here with some kind of allergic reaction, if you don't ask the allergy history, you will be missing out this. If the patient is here with some kind of familial disease, if you don't ask family history, you will be missing out it. If the patient is suffering from such a kind of disease which is due to traveling to such a country where the disease is only limited to that country, you will be missing out this. There are certain diseases, certain cancers which are due to the occupational history. You have to ask this. Likewise, socioeconomic history, and of course, you can ask anything else if the patient wants to add anything. This is the P-Meftosa, and this is the DESA. DESA stands for diet, exercise, smoking, and alcohol. Diet, smoking, and alcohol. Okay. So this makes the major chunk of your history. If this mnemonic will help you remember these things in a better way. if you think something is irrelevant to your case, like if you are not comfortable asking all the questions, it's not a compulsion to ask this question, but you should remember that this will make a major chunk, and you can get things out of it if you remember this mnemonic. After that, you have to ask the patient about the effect of symptoms, because in PLAB-2, you're not only working towards reaching a definite diagnosis. You are there to you are there you are there to ask about how the symptoms have been affecting the patient. It will help you score good in IPS. Like, if of course you can't ask the effect of symptoms in the acute cases, like the patient is here with the heart chest pain, which started 2-3 hours ago. You won't be asking this and that. So if the patient is here with a chronic muscle pain, chronic joint pains, chronic gastroenterology problems, you will be asking that how has this been affecting your life lately? Because I can understand that it can be difficult to handle these symptoms, to get along with your daily work. If you are experiencing these symptoms, especially in psychiatric history, you can ask this. Any chronic disease, you can ask the effect of the symptoms. It will help you score good in the IPS section. Then comes another part, which is an ICE. ICE stands for ideas, concerns, and expectation. And there is no hard and fast rule that you have to ask ICE in only this part, on this segment of the consultation. You can incorporate it in any part of your consultation. So the ICE stands for ideas, concerns, and expectation. So you have to ask the patient that what does he think about whether might be what does he think that might be causing his symptoms. Okay, if he thinks it's a cancer, and if his concern is that I might be suffering from cancer, you get an idea that patient is worried about cancer, and in the consultation, you have to rule out his concern, or to confirm this concern, or to empathize with him during the consultation. So this gives you an idea that how you have to take this case forward. And expectations. Lately, also you can ask that what are your particular expectations from us during this course of consultation. This will help you understand that patient is here was for a simple prescription. Patient is expecting mental support from you. Patient is expecting social support for you. Patient is expecting, what is patient expecting from you? So this will help you steer your case in a better way. Then you have to summarize what you have done. You can skip this part if you're short of time, but you can summarize the positive findings that I took the history. These were the positive findings. You were having pain in your head. You were having shortness of breath. You can summarize all the symptoms, all the positive findings which you have gathered so far in your history above, so that it will be beneficial not only for yourself, but also for the patient and also for the examiner, that you have gotten the gist of the case, and now you are able to proceed further. So after that, you have to explain the patient that you will be going forward with examination. Now, in the case of examination, you simply can't say the patient that I will examine you, because nowadays you don't actually perform, in majority of the cases, you don't actually perform examinations of the patient. You are there just to you verbalize the stuff, and your examination findings will be given to you. Okay, so when the examination parts come, you have to verbalize everything. Like, if you just can't simply say them that you will be recording their vitals. You will be saying that I will be recording your blood pressure, I will be recording your heart rate, your respiratory rate, your saturation, and your temperature. Once you have said these 5 things, then you will be given the readings of these 5 things. If you miss something, the examiner will hide those findings and will only tell you the findings you have asked the patient. And here you can tell about the relevant bedside investigations. Like in UK, the relevant bedside investigation even includes a pregnancy test. You can order an ECG. You can order a urine test, blood sugar. You can order these bedside investigations, which are relevant to your case. But all this will be dependent on what you were saying. For example, if it's an ophthalmology case, you have to verbalize all the examination. If you're not verbalizing, the examiner will be hiding those investigations. Like in ophthalmology case, you have to tell that you will be checking the visual acuity, you will be checking the eye movements, you will be checking that visual acuity, eye movements, field of vision. All these investigations you will be telling, then you will be given the findings about them. So don't forget every relevant investigation. Then if you are given the findings, you can take 10 to 20 seconds to read out of findings. For example, if there is an acute angle closure glaucoma, you will be given about the findings of the eye. So you can take 10 to 20 seconds in order to read out those investigations. And then you don't simply move away. Okay, I have seen the investigation, so the diagnosis is this. You have to involve the patient. You have to tell the patient that your blood pressure is raised, your heart rate is raised, your ECG has this abnormality, your eye movements have this abnormality, your visual acuity is reduced, or everything you find in the paper given to you, you have to explain it to your patient so that he gets to know that what have you what positive findings you have gathered so far. And not only the patient, but also the examiner gets to know that you have interpreted the findings very well. So after explaining the finding, you will explain the diagnosis to the patient. That based upon the history I have taken and based upon the examination I have done, I think you might be suffering, I probably think you might be suffering from a condition known as this. For example, it can be a subarachnoid hemorrhage, or it can be tension headache, or it can be meningitis. Then you have to check the understanding of the patient. That do you have any idea what this condition is? To check understanding, like patient can say, yes, doctor, I know that I know this condition, it runs in my family. Then you can, if the patient knows something, you can ask that, is there any particular point you don't know about, or is there any particular point you are concerned about? Once you get to know about the fact that that person is concerned about this specific thing, you can focus your explanation on that. So first check patient's understanding, and then move towards explaining the diagnosis in a complete detail, like 2 to 3 or 4 sentences maximum. And then repeatedly check that, have you understood what I have said? Are you following me? Once you are done with your history, you have to use these sentences repeatedly. That, are you following me? Are you with me? Have you understood what I have said you so far? So use these sentences repeatedly so that the patient remains involved, and you are not, because it's not a theoretical exam, it's a practical exam, and the people, the examiner, they will be judging you for your IPS skills, for your data gathering, and for your management. So be careful in involving the patient and not giving out all what you have learned so far in your MBBS or during this preparation. Just try to involve the patient into your consultation and repeatedly check patient's understanding. So as far as the next part is that it's a management, it's a detailed section. We will be having a separate lecture on management part, maybe today or maybe tomorrow evening, inshallah. So about the management, the main points are that you have to discuss that whether the patient needs admission or referral, or maybe the patient needs a definitive. You have to discuss investigations, definitive investigation, which the specialist might be doing for him. And similarly, you have to check the symptomatic relief for the patient, and then you have to tell him about the definitive treatment options in this management. We will be discussing management in detail in our next lecture. So next part is the safety netting. We will be safety netting the patient. This is a new concept. We don't do much that in Pakistan, but we have to safety net the patient in PLAB-2, especially, and in the UK setting too. Like, we have to tell the patient that if we are sending the patient home, we have to tell them about the worrisome signs of any case, like fever, fits, sudden weight loss, sudden loss of appetite, feeling extremely nausea, extreme episodes of vomiting. We have to tell them about all the red flags. And if you experience any sudden symptom related to your case, like sudden loss of vision, you have to report back to us. You have to reach back to us so that we can manage that. You can come to A&E right straightforward after you suffer from these symptoms. So after safety netting, you can offer them leaflets. That these are some of the leaflets, so that he can study about his condition in a better way at home. Like if he is suffering from a chronic condition, if he's suffering from any eye disease, you can hand over. You don't actually have to hand over the leaflets because there won't be any. You can tell them you can take the leaflets with us and study about your condition afterwards. You can know about your condition in a better way. Similarly, apart from leaflets, you can, in some cases, you have to tell them about certain websites, that there are certain websites which you can study about, from where you can study about your condition in a better way, in a more detailed fashion. After telling them about the leaflet, you have to tell them about the follow-up. Like in most of the cases, it's a 6 to 4 weeks of follow-ups. Most of the cases, this is a general rule of thumb. But you have to follow the specific cases and advise the patient, yet you have to follow up with us after a few days, and you have to keep a good check on your health. It will be better for you. After that, you have to close your case by saying that I hope to see you in a good health soon. And this is all about the history taking part. So this your total case is about, timing is about 8 minutes. Total case time is 8 minutes. So, and when you practice, you have to practice in 7 minutes. So try to finish the history taking part at least in 5 or 4 minutes, so that there in the actual case, when the second ring bells, which tells you about the 2 minutes remaining, you are almost done with your history, you're almost done with your examination, and you are about to tell the patient about the management plan. This will help you streamline all of your case, and will help you complete the case in time limit. So this is about the history taking. Now our next lecture will be about the management and IPS skills. That will be tomorrow evening, I think so, around the same time. We'll be announcing in the group. So I would like to say, if there are any questions, do let me know, please. Okay, we'll wait for half a minute more, then we will be closing. You're welcome. Okay, I think so. There are no more questions. So let's wrap this session and hope to see you soon in the next class, inshallah.